Hi, my name is Ellie Hagender, and this is my presentation on cystic fibrosis. Cystic fibrosis is a disease that causes our exocrine glands to produce thick, sticky mucus and affects secretions such as mucus, tears, sweat, and enzymes, especially our pancreatic enzymes. Areas affected by this disease include the upper and lower respiratory tract, gastrointestinal tract, integumentary system, and our reproductive system. This disease is found most commonly in Caucasians and males, and the life expectancy is now age 37. This is usually diagnosed within the first year of life. Cystic fibrosis is caused by an autosomal recessive genetic disorder, in which the gene CFTR is mutated. CFTR is a protein that, when functioning properly, regulates chloride, sodium, and water membrane crossing. In cystic fibrosis, the movement of water and sodium into the extracellular spaces is decreased, and also the movement of chloride out of the cell is also decreased. This is what causes hypochloremia in cystic fibrosis patients. The decrease in water in the extracellular spaces causes the secretions from exocrine glands to be less diluted with water and therefore causes extra thick and sticky mucus secretions. In order to get cystic fibrosis, both of your parents must carry the gene, and both of the parents pass down that gene, giving you two of the mutated genes. One of the first signs of cystic fibrosis is the meconium ileus, which is much like a small bowel obstruction for adults. This sign usually presents itself during infancy, which is why cystic fibrosis is usually diagnosed very early in life. If it is suspected that an infant may have CF, then a sweat test is performed. This measures the amount of salt concentration that is in the sweat, and a positive test result would be a value of 60. Now let's dive into a little bit of the pathophysiology of cystic fibrosis. One of the major systems that is affected is the respiratory system. Thick, sticky mucus produced in the lungs causes blockages in the airway and results in a decrease of gas exchange at the alveolar level. This can result in hypoxia, and in patients who had chronic hypoxia will often show this manifestation through nail clubbing. These patients are at very high risk for infection due to the inability to expel mucus from their lungs. Some of the most common infections are Pseudomonas and Staph aureus. These patients are getting respiratory illnesses very, very commonly, and sadly it is almost always their cause of death. Many CF patients also experience emphysema, or hyperinflation and air trapping in the lungs, which can lead to alveolar rupture and eventually pneumothorax. The increased stress on the lungs can also add to pulmonary hypertension and an increase in cardiac workload, and may also lead to heart failure. Many of these patients, especially during an infection, will be coughing up bloody sputum from lung damage, especially caused by that infection. They can also have sinus issues due to all of these sticky, thick secretions, such as congestion, and they can also develop nasal polyps, which may need surgical intervention, and can add to snoring. Next up, we have our endocrine system, or our skin. Now, people with CF will have overproductive sweat glands that add too much salt into the secretions, and this is why we do the sweat test as a diagnostic for this disease. The loss of excessive sodium through sweat can lead to electrolyte imbalances as well as dehydration. As we all know, salt sucks. So if our patient is producing too much salt through their exocrine glands, then they will also be producing a lot of water as well. CF can also affect our gastrointestinal system in places like the small and large intestine, the gallbladder, and the pancreas. In adults, this can present as bowel obstructions because of this thick, sticky mucus. We are also not producing enough water into our digestive tract, therefore making our stools extra sticky and dry, leading to bowel obstruction. In infants, this is described as meconium ileus, but is pretty much the same thing as a bowel obstruction. Now, if you can remember, our meconium ileus is usually the first presentation of cystic fibrosis in infants. Patients can also experience distal intestinal obstructive syndrome, or DIOS. Our common bile duct can also become obstructive with this thick, sticky mucus, causing issues in the gallbladder such as gallstones due to the backup of mucus in the gallbladder. Subsequently, our pancreatic excretions are also affected. When pancreatic enzymes cannot enter our duodenum, this causes problems with digestion that we'll get into a little bit later, and can also lead to pancreatic fibrosis. Lastly, CF can affect the reproductive system. In males, the vas deferens can become obstructed by this mucus, and many males do not actually fully develop their reproductive system because of all of this mucus getting in the way. Females, however, usually develop just fine. However, vaginal secretions are affected as well. These are extra thick and sticky, making it difficult for sperm to travel up the vaginal canal, leading to infertility. Now let's get into some non-pharmacological and pharmacological treatments. I would like to preface this by saying that not every patient is going to have the same regimen of medications, and that it is very much played on a patient-by-patient basis. However, these are some of the most commonly seen prescribed medications in patients with cystic fibrosis. First, let's talk about our non-pharmacological interventions. These are all mostly directed with the purpose of thinning out secretions and also helping to expel them from the respiratory tract. First off, we have chest physiotherapy. This consists of both postural drainage and percussion or vibration. Postural drainage is when the patient is placed with their head lower than their chest to help gravity to excrete those secretions. Percussion and vibration can be done either manually by having somebody create percussions on the back of the person receiving them, or through the use of a physiotherapy vest that creates vibrations. This is done 2 to 4 times a day in 20 to 1 hour intervals. It is always done on an empty stomach and not before or after meals, as this can cause vomit and decrease of appetite. Following PT, these patients are encouraged to use the huff coughing method to help expel any of the leftover secretions that were not expelled during PT. Anaerobic exercise can not only help with the lungs and help to expand and get some more gas exchange, but it can also help with the digestive tract. However, we have to be cautious with physical exercise, as we must account for their salt and calorie intake as well as their hydration status. We want to educate these patients on how to prevent receiving any infections. So we want our patients to be wearing masks, practicing proper hand washing, getting their vaccines, and avoiding people who are sick. We want these patients to have a high calorie, protein, and fat diet due to the decrease of pancreatic enzymes entering the duodenum. We also want these patients to stay nice and hydrated to combat any possible bowel obstructions they may be having, and to also initiate some thinning of those secretions. Lastly, the only true treatment for these patients is a lung transplant, and unfortunately, cystic fibrosis patients may need multiple lung transplants throughout their life, depending on the severity of their disease. Now let's talk about our pharmacological interventions. Patients may be receiving nebulizing treatments that contain bronchodilators, mucolytics, and anti-inflammatory medications. These patients will also need to be on supplements including vitamin D, E, K, and A. These are all of our fat-soluble vitamins that these patients will be deficient of because of the lack of pancreatic enzymes entering the duodenum. These patients may also be on pancreatic enzyme replacement therapy, such as pancrelipase or pancreatin. We want to give these medications an acidic food because alkalytic food may decrease their effectiveness. And we need to be giving this before meals and snacks to promote digestion of whatever they are ingesting. Miralax is also a common drug prescribed to these patients to promote the movement of fecal matter through the digestive tract to prevent any bowel obstructions. And lastly, these patients are going to need antibiotics quite frequently due to their frequent respiratory infections. Two of the most commonly prescribed medications for these patients is tropomycin, which can be delivered IV or through nebulizer, and quinolone, which can be through either an IV or PO. However, we do have to be very mindful of the possibility of antibiotic resistance because these patients are experiencing frequent and repetitive infection of their lungs, many of which may be from the same bacteria, which can often lead to a resistance. Before I wrap up, I'd like to discuss some of the sources that I used for this presentation, starting off with the film 5 Feet Apart. In my personal opinion, I thought that this film pretty accurately presented cystic fibrosis in the hospital setting. This film portrayed the use of chest physiotherapy and the strict medication regimen that these patients are on, especially during time of infection. I think that this movie was very beneficial to watch during the process of learning about cystic fibrosis because it explored the emotional aspect of having somebody with a disease such terrible as cystic fibrosis. I got most of my pathophysiological and pathogenesis information from the YouTube video Cystic Fibrosis Nursing from Registered Nurse RN, and I gathered more information on medications, dosing, and confirmation of disease processes through these books published by Elsevier. Thank you for watching this presentation on cystic fibrosis, and I hope that you have a great day.